there's a mental health disorder and it's a mood disorder. So mental health disorders, we have different types. This comes under a mood disorder. So mood, we are talking about our emotions, our feelings, how we feel. Okay. What is peculiar about bipolar disorder compared to other mood disorders is the fact that with this, an individual tends to experience extremities of mood. And so the bi will be looking at two ends of, or two poles. So bipolar, two poles of a spectrum. And the individual keeps experiencing recurrence of the extremities of these poles. So what are these poles? On one end is what we call the depressive episodes or the depressive phase. And that is marked by the individual experiencing low mood. So there's low mood, which is pervasive, is continuous for a period of time, associated with decreased pleasure derived from pleasurable activities. And so leading to the person either not engaging in these activities anymore, or even when they are engaging, they're not deriving a sense of pleasure from them as they previously did. Along with, so the depressive symptoms we talked about, a reduction in energy levels, alteration in the sleep pattern, so that the person is not able to sleep as well as before. And with depression, one of the characteristic aspects is that the person might sleep and wake up very early at dawn and not be able to go back to sleep. But there are those who might have some difficulty even initiating sleep, or sometimes having very intermittent sleep, so they keep waking up several times in the night. For some people too, when they're depressed, they might actually end up sleeping a lot, so they might be sleeping excessively than they previously did. Then appetite is also another aspect. So some people during that phase might have a really drastic drop in their appetite for food. Others might have an excessive appetite for food. So based on which phase, there are those who might really lose weight, and there are those who might be gaining weight during that period of time. Then there's also the aspect about cognition. So the person might have difficulty concentrating. So though they're engaging in activities, it's difficult concentrating on what they're doing. And some people might even lead to some form of forgetfulness. It looks like they're easily forgetting things during that period of time. There will be associated feelings of hopelessness. When a person thinks of the future and they're thinking about prospective things in the future, it seems like bleak. It seems like nothing good is going to happen. Everything seems so hopeless. And for some people, they also feel worthless. So they feel like they themselves are of little value. They don't matter much. They are worthless. And all of those might lead to someone then starting to have thoughts of, well, then if I'm not here anymore, no one's going to really miss me because I'm not really needed. So my life is not really that valuable. Maybe it's okay if I'm dead. Then it might lead to, okay, then wishing that maybe, okay, I might sleep and not wake up anymore, or maybe when I'm crossing the road, something will just happen to me. But then sometimes I might move on to a phase where someone might want to take certain steps to actually end their own lives. So they might actually start planning on the means of ending their own lives. And that's when we're talking about suicidal ideations and suicidal attempts as well. During the depressive episode as well, people often have a drop in their sex drive and their libido, so they are not as interested in sexual activity as they were before. So all of those characterize the phase which we call the depressive phase or the depressive episode. Now, we talked about two ends of a pole. So the other side, the flip side, is what we call a manic phase or a hypomanic phase. They're kind of similar, but just that the intensity of the hypomanic is a bit lower compared to that of the manic phase. But generally, so manic phase will be characterized with the person having a lot of energy, being very elated, very happy. So we see the mood is expansive. The person is very elated, very happy. Person might be engaged in a lot of activities, goal-oriented activities. So you see that they are up and down, pacing, moving up and down. Sometimes you're not really sure what they're doing, or they might start one project, they might not finish, start another project, not finish, start another thing, because they have a lot of energy and goal-directed activities. Person also have what we call racing thoughts. So they have a lot of thoughts and ideas coming to mind, and it's coming at an increased pace. So that might reflect in what they are doing, their activities. During that period, so with this aspect, the libido is up. So the person is hypersexual. So for someone who initially maybe didn't have any partner, or maybe had just one partner, all of a sudden you realize that they are disinhibited, they are having multiple partners at the same time, oftentimes not using protection because there's increased tendency for risky behavior as well. So the increased tendency for risky behavior might reflect in the person's driving, for example, speeding, doing overtaking and turns that are a bit risky. Or sometimes some people might then dabble or test things like substances. So someone who doesn't drink might now decide to try certain substances amongst others. So there's increased propensity to try things and that are risky. During that phase as well, some people might be a bit over generous. So they might be giving out their items or sometimes even their own money. So in the expenditure, they might not be as conscious or thorough as they previously were. So it might reflect in them losing quite large sums of money within a short space of time, or spending on things they don't need, or buying things they don't really need. Person may also have overinflated self-esteem, so they may see themselves much bigger than they really are, and it might reflect in the way they communicate, and sometimes it might be a bit interesting. But generally, so that kind of also shows the manic phase. So with bipolar, it doesn't mean the person is always in these phases, So the person might have an episode of one of these phases. In my wrap up, they might have a period in between that they are fine, they are back to their usual selves. But another episode will happen again. But you can't predict which episodes will come. And everybody is a bit different. Some people have a bit more of manic episodes happening for them. Some people have a bit more of depressive episodes, and all of that. So based on that, we kind of manage adequately. But generally, I think in a summary, that is what bipolar is. So it's a recurrence of these episodes, the recurrence of these episodes. So this varies, actually. So it varies. So there are some people who have very good insight about their condition. Yeah, they have good insight. They have an understanding of their condition. So there are some people, when they observe certain things about themselves, they even know when it's coming. For the depressive episodes, especially the low mood and all of that, that one, most people would notice that they're not feeling as well. Most people don't like the depressive episodes. From what I'm saying, you see that the manic episode sounds a bit more fun compared to the depressive episode. So most people dislike the depressive episode. So when they're feeling, they might notice it. However, there are some acts during the period that persons might not necessarily fully understand how they're doing it. And subsequently, later, their minds might be drawn back to that, oh, I did ABC during that period, and be regretful of it. So some of these maybe engaging with some sexual activity with someone after a very brief meeting, some people really regret all of those kind of encounters, or even the expenditures. So some people, I've had some clients who would say, later on they came to realize that their bank statement had all of these withdrawals. I can see I withdrew all this. I can't tell what I did with each one, but then I kind of regret all of that. So the extent to which an individual might recall things that happened during the period varies from person to person. But generally, there are some who would notice some symptoms that they know that, oh, I'm getting into this phase, and they'll actually show up and then try and get redress for it. So it varies from person to person. There is a genetic component to it. And there are statistics from if there's a first degree relative, amongst others. That has all shown, twin studies have all shown that there's a good genetic basis to it as well. But then someone being born with a genetic predisposition to a disorder doesn't necessarily mean that 100% they would have the disorder. It just means that there's an increased risk of having it. So having the genetic component whilst you're growing up, when the environmental stressor comes in, then that might trigger it for there to be a physical manifestation for us to see the symptoms. So someone being from a family line with it, we might not know if you have it genetic in there, but then as they are growing up, through life's experiences, sometimes with stress, with school, with the home, with marriage and all of that, that might trigger the episode to start. For some people too, when they try to experiment with some substances, they will say, all my friends smoke cannabis, they are doing fine, then they would attempt smoking it, and then that might trigger their episodes to start. So what happens in the environment might also trigger the episodes to start, and then with recurrence, then we realize that the individual is having the bipolar affective disorder. From a clinician's perspective, it's not easy to just see one behavior and conclude. So you might easily conclude there might be a mental health disorder, but then pinning down to specific bipolar affective disorder, you will need a proper assessment, and that involves a good history about how long the symptoms have been going on, amongst others. Mind you, as I said earlier, someone might actually use a substance or might have taken some medication, some drug. It might trigger a behavior that might look like a bipolar or a manic episode or a depressive episode. Some medical conditions might make someone have symptoms that might look like a manic episode or a depressive episode. For example, a thyroid problem, if it's on the low side, might make someone have symptoms that will look like a depression. If it's very high, it might have make someone behave in a way that looks like a manic episode. So on the whole, just observing someone in public and tagging and labeling based on one behavior is not a good idea. Generally, it's better when the person gets a thorough assessment. All the lab works are done, the blood tests are done, physical examination is done. After a thorough history has been taken, then a proper diagnosis can be made. That is more meaningful. So to make a diagnosis of a depression, generally the symptoms should have been present, especially if there's no intervention, at least 2 weeks. So you're talking about most of these episodes recurrently being present for at least 2 weeks or more. Then we can say the person has a depressive episode. For a manic episode, the symptoms I spoke of being present for at least a week before we can say a person is experiencing a manic episode. Now, how long will the actual depressive episode or manic episode last varies. It can vary from weeks for some people. Generally, I have seen some people who have had it for months. You see, the thing is, as it starts off in the initial aspects, it might be briefer. So shorter period, then the person would have come back to feeling back to their usual self, then another episode. But as this progresses without intervention, the recurrence, the frequency would increase, and then the duration of these episodes might last a bit longer. So then that's where it becomes difficult. So the thing is, you can't really say, a depressive episode is definitely going to last 2, 3, or 4 weeks. So that means when the person starts experiencing, you say, okay, let's wait for the next 2 weeks, it should be over. You can't really predict it that way. Even with interventions, everybody has their episode resolving at a different rate. So it's kind of person to person generally. So bipolar affective disorder is not an infectious disease. So living with someone with a disorder doesn't lead to one contracting bipolar affective disorder. That's not how it works. I've actually had some families come in and not wanting a mom to breastfeed her baby, or even taking a child away from the mom to live in a different with a different family altogether, because the whole thing was like, we don't want this child to get this disorder. But that's not how it works at all. So it's not something that's in the air that is contagious like COVID or all that. No, not at all. Even with twin studies, so you can have twins who are separated at birth, and they both have identical twins who have both got the same genetic bits, and they are raised in different environments. If there are stresses for both of them, they will both have the condition, irrespective of whether they live together or not. So it's got to do with what is in genetically and what happens in the environment, and not necessarily people kind of giving it one to another. So please don't shy away from anybody just because you think they have bipolar affective disorder. It's not something contagious. It's a medical condition, just like how we have hypertension, diabetes, and all the others. You don't get hypertension from staying somewhere. You don't get diabetes from staying somewhere. So it's the same with bipolar disorder. You don't get. So let's stay with people, okay? Let's show love and support. That is more helpful. Yeah, so there are some support, there are some groups that especially are able to link up people who have these conditions. The best would have been to have a bipolar society and all of that. For now, I'm not familiar with any of those yet. But then we have the Mental Health Society of Ghana, MISOG, and they do a lot of advocacy and support for one another as well. So I think by linking up with them, anyone can then be directed to any particular support group that they might need as well. So there's definitely help available in terms of support as well. And so it has an interesting link, just like how mental health disorders have with, well, substance disorder is a mental disorder as well. So let me just give scenarios, okay? So in the depressive phase, for example, persons during that phase are not feeling too great, essentially, they're very down. And people try different means trying to cope with this feeling. And for depression in particular, one of the things that I've been found is that, especially with men, one of the common coping mechanisms people tend to, that is not really helpful. Okay, so we say a maladaptive coping mechanism is use of these substances, with the intent of trying to get some pleasure from it, to kind of lift, with the aim of trying to lift that low feeling. So people might go into taking excessive amounts of alcohol, use substances like cannabis and others, trying to derive the high from it and to address this low mood. On the other side, as I spoke about the manic phase as well, we talked about persons during that phase being in a place where they are a bit more open to experimentation, increased risk behaviors. So persons may now want to try out different things. So some will be willing to try out alcohol, may indulge in smoking stuff they usually wouldn't, or smoking in higher quantities because they're in that space where they are not processing things as thoroughly, and would want to also pleasure driven as well, okay, because they're feeling that great about themselves. I'm God, I'm in that space where I am invincible, so I can do anything. So it has this relation. Now the challenge is that when people get introduced or start using substances, most of these psychoactive substances, that is, these substances that kind of have an effect on the brain as well, because they're giving that pleasure, they are addictive. They have some component that is addictive about them. So that means it's not always just a one-off. When you get the pleasure, your brain learns that, okay, I get pleasure from this substance, and so it will want you to use again because I want that pleasure. So it leads to the person developing that cycle of using of these substances as well. The challenge is that once someone gets into a substance use problem, it worsens the bipolar affective disorder. So it makes someone getting well from the bipolar a challenge. Someone's response to treatment a challenge, and the long-term outcome becomes less great for the individual. So that kind of is the correlation with substance use and bipolar affective disorder. Even with the triggering of the very first episode, so for some people, they might not even know they have a bipolar affective disorder. But as we said, some environmental factors could trigger the person experiencing the first episode. So one of those triggers could be a substance use. So someone can use alcohol, someone can engage in get intoxicated, or someone can use cannabis or some other psychoactive substance. And because they already have a genetic predisposition to having the bipolar affective disorder, for them when they use it, though other people can use it and not have issues, for them when they use it, it would be the triggering factor to them unmasking a first episode of their bipolar affective disorder. We do use pharmacotherapy, that's medications, and psychotherapy. However, there are a few cases where some persons might need a bit more in terms of intervention. So for them, based on the extent to which their case might be manifesting, or at the period when they might be experiencing these symptoms, some additional interventions might be used, including electroconvulsive therapy, amongst others. But it's not the routine. It's in special cases as and when it's needed. I'll say the first thing is being understanding and supportive. Oftentimes, we live in a society where anything about mental health gets stigmatized. People will shroud it with a lot of negativity. Trying to look down on the individual, make them feel like they're a different species or entity altogether. What about down? You're mad, you're crazy, you're not normal, you're abnormal. That tends to be the tone we take. And even when we are doing, if everybody's allowed to be angry, but when the individual gets angry, then we say, well, yeah, now, but so yours is your condition that has come up. So that individual is not entitled to any other emotion other than the ideal. And that does not help the individual do well. So coming from a place of one, showing understanding and love and support, that is extremely crucial. Having a listening ear to the individual when they want to share what is going on with them. And whenever they go into any of the episodes and you notice them moving away from their usual self and you notice that there's a change in the mood, speaking to them in a nice way, trying to draw their attention to it is extremely helpful. When someone engages with healthcare, and it's good to help support someone to even engage with healthcare services. As I said, it's a chronic condition, so sometimes, even with people who are on antihypertensives or diabetes, taking medications for a long period of time, human nature, we get tired. It's normal for someone to feel tired and not want to continue. So that's where we are supposed to be supportive, encouraging. When they don't want to show up for reviews, just encouraging and going with them. All of those acts will go a very, very long way in helping individuals stay well. The support is extremely important. We always say biopsychosocial. So we do the biologic aspect, that's the physical aspect, the psychological aspect which I've talked about, which is the psychotherapy amongst others. But the social aspect, family, loved ones, colleagues, that supports that environment of we understand you, we are here for you, and we will support you. It goes a very, very long way in helping people do well and stay well. So the Mental Health Act of 2012 speaks to that. It talks about supporting the rights of persons with mental disorders and disabilities as well. And it clarifies that so just because someone has a mental condition doesn't necessarily mean you have to let go of them at work. There's a responsibility of supporting them in accessing healthcare and receiving healthcare, just as we do for other medical conditions. So that is what the act says, and now the legislative instrument has also been passed, so it kind of gives it some backing. But that's not to say that when persons have this disorder too, they should also take advantage of the system and say that I can't be let go because I have a mental disorder. If you're found not to be adherent, not seeking medical help, and not trying to kind of liaise with your healthcare providers in ensuring you are well, and repeatedly you are not performing as you expected because you are unwell and not getting treatment, then these things, there's some room to let go because you are also not playing your part. So both parties, per the law, have a responsibility. So that's generally it. But as you can understand, most people are not willing to divulge the diagnosis to their employers because our system doesn't really understand mental health issues. Most people, all the diagnosis doesn't really matter. The bottom line is that there's a mental health condition. We should be wary of you and we should be thinking of how to let you out. So that's where our society is, and we're hoping that the education would improve so that managers, employers, and supervisors will be better abreast with these things so that they know how to better assist persons who come to them with these conditions. I'll say we can start from talking a bit more about it in different settings, because anyone can be affected. So in churches, in mosques, in schools, in workplaces, it should be something we're talking about on our media spaces. It should be something we're talking about a bit more. And what I think has helped a bit more now is because some people of prominence have had some public um, experiences with their symptoms. So it kind of brings everyone's mind to it for the conversation to be started a bit. So we've had Archbishop the Chameleon Susan, Funny Face, and a few others having some episodes. So it makes everyone see that it can happen to anyone, and then the conversation gets started. But it's just a starting point. So we should talk more about it and we should demystify it.